My name is Candace Politti. I'm a certified nurse midwife and nurse practitioner. Today I'll be showing you how to deliver babies in different positions. And now let's get started. In a normal vaginal birth with the head presenting, you'll see the head crown, and as the head crowns, you support the baby's head as it emerges through the pelvis. As the head delivers, you're going to reach down and feel down to the shoulder for a nuchal cord. You'll feel if there is a nuchal cord, then you'll gently take it, if it's loose, and reduce it over the baby's head. If it is tight and you cannot reduce it, then the baby will more than likely be coming through the pelvis, and you will just deliver through. But this cord was loose, so the baby's shoulder, anterior shoulder will deliver, and then you'll just give some support and pressure down to help deliver the anterior shoulder. And then as that shoulder is delivered, you'll reach and give the baby some upward pressure, supporting the head the whole time. As the baby's body delivers, you'll just support the body, bring the baby up onto the mother's chest, and then you will palpate the cord for heart rate, and the baby will be crying, stimulate, dry, and leave the baby here with the mother. As long as the baby is breathing and pink and all those things, then you'll be checking and wait for the cord to stop pulsating before you clamp in one place here. Then you'll milk it down, and then you'll put another clamp, and then you'll cut. Usually the delayed cord clamping while the cord is pulsating usually takes 3 to 5 minutes. And once that's done, you can just leave the baby with the mother and keep the baby warm and check for the vital signs and stability of the mother and the baby. This baby is presenting in the shoulder presentation. Most of the time you'll see outwardly that the uterus will be in an oblong shape transversely, and you will not find a presenting part sometimes, but if you do, you may see a shoulder trying to emerge or an arm that will come out of the vagina. At this point, this is a medical emergency, and this baby will not be delivered vaginally. She will need to be delivered in the hospital by C-section as emergently as possible. So you will put the patient into the knee-chest position, taking the pressure off of the presenting part, and get her to the hospital and call ahead that this baby will be needing more than likely operative delivery. In face presentation, the only way a baby will deliver vaginally is if the chin or the mentum is anterior. So what you'll be doing is encouraging, once the baby delivers, also if you find that the baby is mentum posterior, this is not feasible, and this baby will not deliver vaginally. And most of the time the babies will rotate, but at this point, if the baby is presenting in this position, then you need to put the mother in hands and knees chest, and on her hands and knees in knee chest position, and get her to the hospital and just support the mother and support her mentally and physically. So, but now you have this baby has rotated, which they most of the time do. They rotate, and then this baby is going to come down, and then the head will flex, and then the baby will rotate, and then this is where you're going to be checking for that cord. And there's no cord. You're going to support the baby's head and then give downward pressure to get the anterior shoulder delivered, and then give upward guidance to help the posterior shoulder deliver, and then the baby will come out. You will put the baby up on the mother's chest, dry, stimulate, and do your delayed cord clamping. Wait until the cord stops pulsating, and then you're going to clamp, milk, clamp, and cut, and then support the mother and the baby. This baby is presenting in the breech position. Breech is either feet or the buttocks. what you will typically see is meconium coming out of the vagina and a butt or a foot or 2 feet emerging. At this point, you will just let the baby come on his own. He will deliver, come down, and as the pressure and the uterine contractions bring the baby down, you'll be hands off. This is the baby's legs will spontaneously deliver. And then once the baby is at the level of the umbilicus, you'll take a loop of the cord, bring it down, and then you're going to wrap the baby in a dry, warm towel. You will encourage the baby to turn face down, and as the anterior shoulder comes, you can go ahead and help deliver that anterior shoulder with some downward pressure, and then the posterior shoulder deliver with upward guidance. Then you encourage the baby to face down. As the baby is facing down and the powers of the contractions and the mother's efforts, the baby will come down and you will reach underneath and put your fingers just under the nose and encourage flexion of the head. And then the head will deliver, bring the baby up, and then the baby will emerge. At this point, bring the baby up on the mother's chest, dry and stimulate the baby, and watch for vital signs, check the vital signs, make sure baby's breathing. Also, you're going to do your delayed cord clamping. You're going to clamp, milk, clamp, and cut after the cord stops pulsating. When you come into contact with a patient who you see that there is an umbilical cord coming out of the vagina, then this is considered a cord prolapse. This is a medical emergency, and the mother needs to be repositioned into a knee-chest position to take the pressure off of the head, pressing on the cord against the pelvic bones of the floor, and it will occlude the blood to the baby and oxygenation. Therefore, put the mother in knee-chest position, and you're going to push the presenting part off of the cord, and just to give it support if you can see it at the vagina. Then you can go ahead and give pressure and just encourage the woman, give her support, and get her to the hospital and call ahead and let them know that there is a cord prolapse and that more than likely they will be needing to get the OR ready.